And after that, the saws are placed on the bone and is dissected the bone. All the tissues during the surgery is dissected from left to right. And during making the sutures of these layers, yeah, suturing is performed from right to the left side, and is all the tissues are dissected layer by layer. During recovery from the surgical operation, all the tissues are restored, are sutured layer by layer. Different types of surgical operation. We have told the classification of the surgical operation, and one of the type is what? Bloody operation, yeah, where is performed the dissection of the tissues. When there is formed the dissection of the tissues, there always starts bleeding, always starts during dissection of the tissue, bleeding. So that's why it is called bloody operation, yeah, which must be stopped right away, not to get the complication. Because main complication of the surgical operation is bleeding. Bleeding, which may cause the fatal result of the patient. So that's why when we have the bleeding, it must be stopped right away. So main complication of the surgery is bleeding, and also is spreading of infection from one region to other region. Many methods we have to stop the bleeding from the vessels. We have told that instruments are used for stopping the bleeding. Clamps, yeah, different types of clamps we have, which are used for stopping the bleeding. Also, for stopping bleeding from small vessels, maybe used electric knife, but it can't be used on the magistral vessels. One of the methods of stopping bleeding from the magistral artery is ligation method. Ligation means to put the knot on the vessel, and I have shown you, as I remember last lecture, yeah, method, how is performed technically. So at first, when it's bleeding from the magistral artery, must be applied the clamp on the vessel. Then is applied what? First knot around the artery, and when it is tightened, is removed the clamp to check if there is bleeding from the vessel, and is applied second knot. Yeah, differences between these knots when we apply ligature on the magistral artery. Two ligatures. Peripheral ligature is suturing, so needle with thread passes into the artery, and so it is sutured, and after that is applied the knot, but central ligature is common. So why? Because why peripheral ligature is suturing? Because to avoid splitting down the ligature from the artery. So complication of this procedure when we apply the ligature on the vessel is it may be opened, and as in the artery, blood flows from central part to the peripheral part. So with high pressure goes the blood to the peripheral part. So to avoid this opening of the ligature, that's why peripheral ligature is suturing. But ideal manner to stop the bleeding from the artery is when is applied sutures on the artery. So sutures when central and peripheral part of the vessel is sutured to each other. Why it is ideal manner? Because it provides restoring of the normal circulation of the blood flow in the lumen of the vessel. But are cases that in every case of the trauma of the artery, it's impossible to apply vascular sutures, and that's why we have other methods, yeah, such as ligation method. So in this case is used the other methods of stopping blood flow. When we talk about vascular sutures, basic requirement, so if we suture the vessel, basic requirement of the vascular suturing is that it must be hermetic, it must provide minimal narrowing of the lumen of the vessel, and during making vascular suturing, central and peripheral part of the vessel must sutured by intima layer. So intima to intima layer must touch the central and peripheral part of the vessel during applying the sutures on the vessel. Different methods are used of the vascular suturing. We have manual method and we have mechanical method of vascular suturing. Manual method is the method where for the performing of the procedure we need what? Vascular clamps, we need needle, thread, needle holder, and different types of the manual methods we have, which get the surgeons' surnames. And from these methods are widespread the Karel's method and Karel Morozova's method. Karel was the first surgeon who has at first applied the suture on the vessel, so that's why that method was called the Karel's method. And after some time, other surgeon has applied the vascular sutures on the vessel. Morozova, he has done some changes in this Karel's method, and that method has get the Karel Morozova's name. Needle which is used of the vascular suturing is atraumatic needle. Thread is used non-absorbable monofilament thread. Why? Because we have told that atraumatic needle is used for the tender structures, not to get the trauma of the vessel. Monofilament thread to avoid narrowing of the lumen of the vessel. To achieve the hermetism of the suturing, which is one of the basic methods of the vascular suturing, pricking needle from the edge of the vessel must be minimal, 1 millimeter, and during applying of the sutures on the vessel, between each curves, distance also must be minimal, 1 millimeter, to achieve the hermetism of the suturing. But for mechanical method of vascular suturing is used the special instrument which consists of two baths, where is placed the tantalum threads, staples. These are the suture material of the mechanical method, and in this baths is placed the central and peripheral part of the vessel, which is holding on these staples, and the instrument is closed and it automatically sutures the vessel. I will show now the video, and on this video we better understand this procedure. Now let's see the method, one of the manual methods which is applied on the vessel. This method, what we see now, it's Karel Morozova's suture. Now I switch the video and you tell me, do you see the video now?
Yes, we can see your screen.
Yes. So I switch the video. We see the one part of the vessel. This is one part of the vessel which is wetted by physiological solution. So during the procedure, the lumen of the vessel is wetted by physiological solution, not to get the trauma of the vessel. Also, the lumen of the vessel, we see it's isolated from the surrounding tissue. So first, what is done before there starts the suturing of the vessels on the vessel is applied the vascular clamps. I will see this is vascular clamps. Central and peripheral part of the vessel is applied the vascular clamps, which has straight ends, and after that starts isolation of the lumen of the vessel from the tissues. Also it is wetted by physiological solution not to get the trauma or not to get the drying of the vessel. We see how it is isolated from the tissues. Now we show other end of the tissues. Other end of the lumen of the vessel, how it is wetted and cleaned the lumen inside by physiological solution. If there is any foreign bodies, it will be removed from the lumen of the vessel. And after this, after the vessel is prepared, on the vessel is applied two fixation stitches. So during Karel-Morozova stitch is applied two fixation stitches. A fixation stitch is guy suture. What means? I look one end of the lumen of the vessel. Pricking is minimal from the edge, 1 millimeter. Is applied one fixation stitch, which is tightened. Is tightened. We see, and central and peripheral part of the vessel is pulled to each other. This fixation stitch, what provides? It provides touching of central and peripheral part of the vessel to each other by intima layer. We have told that one of the basic requirements of vascular suturing is what? It must be touched to each other by intima to intima layer. Yeah. Then second end of the vessel, look, second end of the vessel is applied second fixation stitch, second fixation stitch, and it is tightened. And when is applied these fixation stitches, yeah, after that starts applying the suture between these two fixation stitches on the lumen of the vessel. And look, it starts applying the stitch. A difference is what is between Karel's and Karel-Morozova suture. So Karel was at first surgeon who has at first applied the vascular suturing. So he has applied 3 fixation stitches of the lumen of the vessel. Then these fixation stitches are stretched and intima to intima layer, central and peripheral part of the vessel was touched to each other. And after that, after some years later, yeah, Morozova has done this method on the vessel, and he has done some changes, I have told you. So he thought that it's enough to apply 2 fixation stitches instead of 3, and that's why this method gets the Karel-Morozova's method. So that's why of 2 fixation stitches are applied on this procedure. This is Morozova's method. Yeah. So after that, between these stitches was applied overhand stitch applies. The surgeon continues overhand stitch between each curves distance must be minimal, 1 millimeter. on the vessel must be applied, may be applied interrupted knotted stitch, and may be applied uninterrupted overhand continuous stitch. It depends the thickness of the lumen of the vessel. For more big caliber of vessel is applied interrupted knotted stitch. For more or less small caliber of vessel is applied overhand continuous stitch. Now is not shown the following procedure of the suture, but look, he shows us how the vessel was sutured. When it's finished, here is not shown. When it's finished, the manual vascular suturing, what is done? At first, surgeon removes the vascular clamp from the peripheral vascular clamp from the artery to check if there is blood flow from these sutures, what he has applied. He must check. Are cases that during making manual suturing, from the stitches, what was applied, there starts what? Bleeding, blood flow. So this means that this suture is not hermetic. So if it is not hermetic, at that level, where starts bleeding from the lumen of the vessel, must be applied the additional suture to achieve what? Hermetism of the suturing. Other method we have told is mechanical method of vascular suturing, for what is used what? Special instrument. We will see now this instrument. So for this procedure also central and peripheral part of the vessel is applied the vascular clamps, and it's separated from underlying layers. And instrument which is used for this is this instrument, which consists of two puffs where is placed, look, staples, and these are staples, tantalic threads it is called, the suture material. One end is placed central part of the vessel, other end is peripheral part of the vessel, which is turned from inside outside and is holded on these staples. Let's see how it is done. So it's turned, look, from inside outside the lumen of the vessel and is holded on the staples, tantalic threads. Tantalic threads, one side and the other side. What advantages has the mechanical suture? Mechanical suture has many advantages. It is performed faster, quickly than the manual method. It never narrows the lumen of the vessel. It is always hermetic. But one disadvantage has this method. It needs wide area for performing. So if we have bleeding deeply in the wound, can't be used the mechanical suture, because mechanical suture needs what? Wide area for performing this procedure. So instrument is closed, look, and it automatically sutures the vessel central to the peripheral part. And disadvantage of the suturing is what? That it needs a wide area for performing. Checks now, doctor removes what? Vascular clamps. Yeah, look, it's hermetic. There is no bleeding from the lumen of the vessel. Do we understand?
Yes, ma'am.
Yes.
Doctor, could I ask again?
Yes.
Mechanical instrument that they were using. What was it called again?
What?
What was the name of the mechanical instrument that they were using for suture?
Mechanical method suture material is staples, which is also called tantalum threads.
Tantalum threads, right?
Tantalum threads, yeah.
Okay, thank you.
Okay. So we continue now, student. We are starting today also the head region, clinical anatomy of the head. One moment, I share now presentation. Do we see the pictures?
Yes, ma'am.
Yes, we see. Okay. Head. We have different form of the heads. We have dolichocephal form of the head, brachiocephal form of the head, and mesocephal form of the heads. How is measured this form of the heads? This is measured by the ratio of the width of the head to the length of the head, and which is multiple 100, and we get the index. And this index for dolichocephal form of the head exceeds from 75.9 up to 81. For mesocephal form of the head, it does not exceed from 76.1, but for brachiocephal form of the head, it is 81 and more. Width, we have told ratio of the width to the length. Yeah, width is measured between most remote points of the parietal bones, and the length is measured from glabella to the external occipital protuberance, most remote point of the occipital bone. Surgically, it is important because during surgery, surgical intervention of the head region, different forms of the head, from these forms of the head, normal shape is mesocephal form of the head. But dolichocephal and brachiocephal form of the head, operative access to the structures of the cranial cavity is formed differently. So clinically, that's why it's important access during the surgery to the structures of the region. Also, we have a frontopetal form of the head, and we have occipitopetal forms of the head. What means frontopetal form of the head? Frontopetal form of the head is that form where most part of the head is located anteriorly to the linea biauricularis. Linea biauricularis is the line which connects external acoustic meatus from one to another. So when most part is located anteriorly to this line, such head is form of the head is called frontopetal form of the head. So person with wide forehead. This is called frontopetal form of the head. When most part of the head is located behind the linea biauricularis, such head is called occipitopetal form of the head. Head region is divided into cerebral part and facial part. Cerebral part of the head consists of the fornix, and this is fornix what we see, and also it consists of the base of the skull. Base of the skull is this area, which consists of the external base and internal base. Internal base, which is located inside the cranial cavity, which is composed of the three cranial fossas, anterior, middle, and posterior cranial fossa. Fornix, what we have told, one part of the cerebral part of the head, consists of three regions. It consists of the fronto-parieto-occipital region, it consists of the temporal region, and it consists of the mastoid process region. Fronto-parieto-occipital region anteriorly is bounded by superior margin of the orbit. Posteriorly, it is bounded by superior nuchal line and external occipital protuberance, and laterally, it is bounded by superior temporal line. Fronto-parieto-occipital region is covered by soft tissues layer, scalp, which consists of 5 layers, and below the soft tissue is located the bone. First layer of the fronto-parieto-occipital region, every region is the skin, which is thick and dense on this region, is less mobile. Under the skin is located, look on the picture, subcutaneous fat tissue. Subcutaneous fat tissue, which includes superficial vessels and nerves. And all these vessels, what is located in this layer, are branches of the external carotid artery. And some branches are from internal carotid artery. So, main artery which supplies the head region, cerebral part and the facial part of the head, are branches of the external carotid artery. In the subcutaneous fat tissue, we have superficial branches of these arteries, which provides blood supply of the superficial layers of this region, and except the arteries, in the subcutaneous fat tissue is located fibrous septus. Fibrous septus, which connects the skin to the underlying layer, muscular layer, and that's why these three layers are closely connected to each other: skin, subcutaneous fat tissue, and the muscular layer. So during surgery, to separate these three layers from each other, it's impossible. So these three layers are dissected together because it's impossible to dissect these layers from each other by fibrous septa. It is connected to each other, skin and the muscular layer. So after below the subcutaneous fat tissue, we have muscular layer, which consists of the anteriorly by frontalis muscle, posteriorly by occipitalis muscle, and these two layers are connected to each other by aponeurotic layer, which is called galea aponeurotica. This white is galea aponeurotica. So in the muscular layer, we have, I repeat, a frontalis muscle, occipitalis muscle, and between them is galea aponeurotica. Under muscular layer, we have subaponeurotic layer. Sub means below, subaponeurotic layer, which includes loose areolar tissue. And also in this layer, we have vessels and nerves, and we have veins, which are valvulus, which is called emissarial veins, and these emissarial veins are connected to the superficial veins of the subcutaneous fat tissue, and these veins also is communicated to the diploic veins, which is located in the diploic layer of the bone, through the venous sinuses, which is located in the cranial cavity. This layer, subaponeurotic layer, is called dangerous area of this region. Why it is called dangerous area? Because here from this layer, if here in this layer spreads inflammatory process, by these emissarial veins, it may be spread through the cranial cavity. Why? Because emissarial veins are communicated to the venous sinuses via what? Diploic veins. And if we have bleeding in this layer, subaponeurotic layer, and this bleeding freely moves according to the frontoparieto-occipital region. Freely. Why? Because it consists of loose areolar tissue, we have told, and bleeding freely moves along the frontoparieto-occipital region, and from forehead it may spread down to the tissues which surround the orbit, and that's why such patient has black eyes. So skin of this area is black. Why? Because below the skin if there is bleeding. And this is one of the clinical symptom of the understanding that bleeding we have in which layer? In subaponeurotic layer. Below the subaponeurotic layer, we have pericranium. Pericranium, which is attached to the bone only at the level of the suture. So we have told that periosteum is attached to the bone closely, yeah? But on this region, pericranium is attached to the bone only at the level of the sutures of the bone. You know, each bone is separated from each other by the sutures, yeah? Frontal bone from parietal bone is separated, connected by the sutures. Parietal bone from the occipital bone is separated from the sutures, connected by the sutures. Yeah, the pericranium is attached to the bone at the level of the sutures. So this means what? That under the pericranium, we have space, and this space includes loose areolar tissue. So this means what clinically? That if we have inflammatory process in a subpericranial space below the pericranium, it is limited along one bone, so it can't spread in other part of the bone. Why? This attachment does not give chance it to spread to other part of the bone. So subpericranial hematoma or inflammatory process is limited along one bone. So I repeat, soft tissues of the frontoparieto-occipital region consist of the following layers: skin, subcutaneous fat tissue, muscular layer, which includes frontalis occipitalis muscle, and between them galea aponeurotica. Below muscular layer, we have subaponeurotic space, and below the pericranium, below the subaponeurotic space, we have pericranium. Clinically is important location and content of the structure. Some of the layers we have told. We have told that in subcutaneous the tissue is located what? Fibroceptors, and also what? Superficial vessels and nerves lies. Yeah, here. These superficial vessels, which is located in subcutaneous fat tissue, outer layer of these vessels, outer layer of the arteries are which layer? Adventitia, yeah? Adventitia of these vessels are closely attached to the fibroceptors. Clinically, this is also important because when there is bleeding, so during trauma, if these vessels are damaged, lumen of the vessels, yeah, superficial vessels, there starts severe bleeding. So severe bleeding, it can't be stopped. Why? Because these vessels can't contract itself. Why it can't contract? Because adventitia of these vessels are attached to the fibroceptor. So we must press by fingers or pressing weight on the vessel to stop the bleeding from these arteries. It can't be stopped. vessels can't be contracted, and clinical describing of this is that adventitia of these vessels are closely attached to the fibrous septus. Below the soft tissue of the frontoparieto-occipital region is located the bone, which consists, look, it is cutted on this picture, consists of three layers. Lamina externa, outer layer of the bone, lamina interna, inner layer of the bone, and between them is located diploid layer, which consists of diploid veins, it's spongy tissue between these two compact bones, which includes the diploid veins. These diploid veins are communicated to the emissaria veins of the subaponeurotic layer, and also it is communicated to the venous sinuses, which is located through the cranial cavity. So this is way of spreading of bleeding and inflammatory processes from subaponeurotic layer through the cranial cavity. We have told that all these layers of the head region is supplied by branches. Most branches are from external carotid artery, and some of the branches we have internal carotid artery. Let's remember now origin of these vessels. External and internal carotid arteries are branches of the common carotid artery. So in the neck region, in carotid triangle, common carotid artery gives off external and internal carotid arteries. External carotid artery gives off branches, and most branches of this artery supplies the head region. Anterior part, this is frontoparieto-occipital region, yeah? Anterior part of the frontoparieto-occipital region. So anterior part is which part? Frontal part, yeah? It is supplied by supraorbital and supratrochlear arteries. Supraorbital and supratrochlear arteries are branches of the ophthalmic artery from internal carotid artery. Arteries are accompanied by same named veins, supraorbital and supratrochlear veins. Posterior part of the frontoparieto-occipital region is supplied by posterior auricular artery and occipital artery. These arteries are branches of the external carotid artery. Parietal part of the frontoparieto-occipital region and also temporal region are supplied by branches of the external carotid artery. Terminal branch of the external carotid artery, which is superficial temporal artery. So from these arteries, the biggest artery is superficial temporal artery, which is termination of external carotid artery. It supplies the parietal part and the temporal region. These arteries, branches, are communicated anastomosis to each other. So scalp has very rich blood supply. Arteries are accompanied by same named veins. These arteries, what we have told, is located in superficial layer. So it lies in subcutaneous fat tissue, which provides blood supply of the skin region. Except the arteries, in the layers, we have the nerves. Nerves, most branches of the tissues of this region are supplied by the branches of the trigeminal nerve. Trigeminal nerve is fifth cranial nerve, which consists of three divisions: ophthalmic, maxillary, and mandibular division. You know this. Anterior part of the skin of the frontoparieto-occipital region is supplied by supraorbital and supratrochlear nerves, which are branches of the ophthalmic division of the trigeminal nerve. Temporal part, parietal part is supplied by auriculotemporal nerve and zygomatico-temporal nerve, zygomatico-temporal nerve and auriculotemporal nerve. Auriculotemporal is branch of the mandibular division of the trigeminal nerve. Zygomatico-temporal is maxillary division of the trigeminal nerve. Posterior part of the frontoparieto-occipital region is supplied by lesser occipital nerve and greater occipital nerve. Lesser occipital nerve, look, it is a branch of the cervical plexus. Greater occipital nerve is formed by C2 nerve from cervical plexus. So all these branches, what we have told, provides sensory innervation of the this region. So skin of this region is supplied by this nerve, but except this, below the skin layer, we have told the is located what? Muscular layer, muscles of the frontoparieto-occipital region is supplied by branches of the facial nerve. Facial nerve is also cranial nerve. It is 7 cranial nerve, which leaves cranial cavity by stylomastoid foramen, and it provides the innervation of the muscles of this region. Okay, we finished today. We don't have time, and following regions, we continue, student, next week. Do we have any questions?
No, doctor.
Okay, following region, temporal region, facial part of the head, we continue next lecture. So if we don't have questions, we finish today, student.
Okay, doctor, I just want to check something from page 19 till 26, this portion is, right?
Yes, vascular sutures are these pages from 19 included to 22, but head region starts from 26 page. So start also reading head region from 26 page, included 30 page.
So from 19 to 22 and from 26 to 30.
30 page, yes. These are pages in the textbook, yeah. Yes. Okay. If we have any question, ask me.
For me,
No?
no.
Okay. So thank you and goodbye. See you next week at the lecture.
Goodbye, doctor.
Bye.
Thank you, ma'am.
Bye.